I'm Celia Kitzinger from the Department of Sociology in the University of York in England.
And I'm Jenny Kitzinger from Cardiff University, the School of Journalism, Media and Cultural Studies, and that's in Wales. And the project we're working on is called Coma, Consciousness and Culture, Medical Decision-Making in the 21st Century. The project is looking at medical decision-making on behalf of people who've lost capacity to make those decisions themselves. And more in the 21st century, we will face this problem for ourselves or our loved ones, that people are needing to make life and death choices in situations where they can't do it for themselves, and that may be because of extreme dementia or the field that we're working in, which is catastrophic brain injury. And we're looking at the ethical, social, political, and economic and legal context of how you make those decisions.
We got into this research because we have a sister, Polly, who was catastrophically brain injured in a car accident 2.5 years ago. We both have a background in communication research. Jenny from a sort of macro level based on analyses of things like media images and health promotion messages, and myself from a micro perspective like doctor-patient communication. But neither of us had studied brain injury or coma, vegetative states, minimally conscious states before. So we found ourselves thrown into a very new sort of research setting.
It did build on some other work I'd done on the ethical debates around emerging technologies. So I've done a lot of work on the debates around stem cell research or nanotechnology or GM crops, and what are the issues as a society for what we decide to invest in, and the way in which those medical technologies are used to support human health and well-being and not to cause problems.
And both of us have been heavily involved in various kinds of politically and ethically engaged research, for myself particularly around lesbian and gay issues, and the way in which personal lives intersect with social and political realities, how individuals can challenge systems, how individuals can change things. So I think we brought quite a lot of shared skills to the project of figuring out initially, how could we help Polly? What could we do for Polly? How could we make sure Polly's voice was heard in a situation where first in a coma, then in a vegetative, then a minimally conscious state, and now with profound neurological deficits, what she would want in this situation could be heard. One of the distinctive features of this research is because it has a personal element, and we're weaving the personal into our sociological and communication studies research. Another way in which it's novel is that the legal situation has changed recently in the UK with the introduction of the statute, the Mental Capacity Act, which lays down legal requirements for how people who lack capacity, how their views, values, wishes and beliefs should be treated. So there has been no previous study of how this new piece of legislation is or isn't implemented in practice.
And one of the things we found very early on was that there's a massive silence or just a series of stereotypes around what it means to have someone in a coma or to make decisions on their behalf, which actually connects back with some work that I did as well on child sexual abuse back in the 80s, where it wasn't a recognised problem, there was a huge taboo about discussing it, and there were just some stereotypes about provocative lolitas. And families there who'd gone through this experience weren't being heard. And as we went through both our own experience as a family in the hospital and also meeting other families, it became very clear that there were some endemic problems here and some huge cultural silences, and that families were left carrying these problems and trying to do right by their loved one in a cultural situation, a legal situation that wasn't always supporting that person's autonomy or that person's best interests or a way of being a loving partner, friend, sister, child of that person.
The Mental Capacity Act, which was implemented in England and Wales in 2007, is the first time there's been a statutory right for people to write a living will that has any legal validity. Very few people have them as a result, 3%, and Polly was one of the people who didn't. So on the whole, people are having to make decisions on behalf of people who've left no formal, written, legally binding instructions about what should happen in this situation. But one of the great things about being here at Bellagio was that when we gave the before dinner talk to the local residents, we researched everybody's country, what the legal situation was. So the comparison with the US is the most stark, where every state, I think, now has the situation where there's an availability of writing a living will, and where doctors generally take those very seriously if they're available to them at the time when those decisions have to be made. But we also checked across the countries of some of the other residents who are here at the moment, which included the Cameroon, Japan,
Norway,
and various other nations, to find out what the situation was there. And that was a very useful exercise and generated some quite interesting discussion. And in fact, the situation is somewhat better, we discovered, in England and Wales than in other countries.
I think our work is quite distinct from other work in the field in several respects. One of those is that while our work connects with the broader field of ethical decision-making about end of life, for example, for people with dementia, or the very beginnings of life, when you have extremely premature babies born at the very margins of life, our work focuses on brain injury, and that has some very distinct criteria. One is that, unlike the extremely premature baby, the person who loses capacity suddenly, for example, in a car crash, had a prior existence where they could express their values and beliefs and the kind of way they wanted to live. So they had some capacity that's been suddenly taken away that you can use as a basis to try and explore what might be the right decision for them and what they would have wanted. The second thing is that, unlike dementia, which comes on slowly and people can sometimes accommodate and adapt to that, brain injury is sudden. You are driving away from a conference, you're a head-on crash, and overnight, in an instant, you are rendered incapacitated and unable to make your own decisions. It's distinctive from other types of gradual loss of capacity because it's very sudden, and also because you are snatched from the jaws of death. Catastrophic brain injury usually means that your body shuts down. You may technically even be dead for a moment. Your heart stops, your lung stops, your ability to swallow stops, and it's medical technology that will bring you back from the jaws of death. And then often during the first few months there will be a series of near-death experiences such as pneumonia. So the family is making decisions all the time about whether to pull people back, or in the UK it's the doctors who make that decision, informed by the person's prior values and beliefs, among other things. And a final difference is that all the thinking that's gone into good palliative medical care for people who are terminal, the lessons from that are not always being brought to the situation of someone with profound and catastrophic brain injuries on the borderline of life and death. Because, given the progress of medical technology, and given many of these people are young, our sort of age or younger, they can be kept alive for 10, 20, 30 years. And so they are not deemed end of life and can't access good palliative care.
Being here at Bellagio has offered us a wonderful opportunity to work together. It's been fabulous. We live in 2 different countries, England and Wales. We live 5 hours drive apart, and geographically between us is our sister. And so when we meet, it tends to be over her body and dealing with issues around her medical care. This has given us a space, a sanctuary, a place to come together without carrying responsibilities, to theorize what we're going through, to stand back a bit, to analyze our own and other families' experiences, and to work intensively on the project together.
And I think also because we come from different disciplines and we're working in an interdisciplinary way, there's something about the very sustained time together. Breakfast, lunch and dinner, there is no escape for us to sort through the ideas, the different literature that we bring to this, and to struggle and wrestle with the data from the interviews with families, bringing our different data analytical skills and our different theoretical perspectives.
The other thing about breakfast, lunch and dinner is every resident has a story of a parent, a grandparent, a relative who's been ill and died in medical systems across the world. And it's certainly sharpened our thinking about the relationship between the brain injury experience in particular and other kinds of terminal illnesses, other kinds of political and healthcare frameworks within which people experience end-of-life decision-making.